Hi everybody, and welcome to our module on atrial fibrillation and flutter. We'll start by talking about atrial fibrillation. Atrial fibrillation is a cardiac arrhythmia. It results in an irregularly irregular pulse, and I've bolded the words irregularly irregular because that is the classic description of this arrhythmia in a board question. It can lead to symptoms of palpitations, fatigue, and dyspnea in some patients. We'll talk more about that in a minute, and the diagnosis is made by obtaining an EKG. At the bottom of this tracing is an EKG from a patient in normal sinus rhythm. You can see that there are P waves followed by a QRS complex followed by a T wave. At the top of this tracing is a patient in atrial fibrillation. You'll notice that there are some bumps before the QRS complexes, but they are not organized regular bumps like the P waves. They are highly irregular. These are called fibrillatory waves. You'll also notice that the QRS complexes, which are what generate a heartbeat, are occurring at an irregularly irregular rate. So for example, there's a short space between these two here, followed by a long space, and then a short space, and then a long space. So it is irregular, and there's no pattern to the irregularity, thus it is irregularly irregular. And here's a full 12-lead EKG from a patient with atrial fibrillation. Once again, notice that the baseline is sort of wavy with little bumps but no defined P waves. Notice also that some of the QRS complexes are relatively close together like these two, others are further apart like this. This is an irregularly irregular rhythm with an absence of P waves, and that is consistent with atrial fibrillation. And then finally, here's another EKG. This patient has a much faster heart rate. You can still see that the QRS complexes are sometimes close together and sometimes further apart. There are bumps between the QRS complexes that you might think are P waves, but these are actually T waves. And if you're confused about that, when you find two QRSs that are further apart, like these two that I'm underlining, you can see that there's no P wave before the QRS. You can also see that the bumps you're seeing in other sections of the EKG are definitely T waves. So once again, you've got an irregularly irregular pattern with an absence of clearly defined P waves. That is atrial fibrillation. Let's talk about what's happening in atrial fibrillation on a cellular level. So normally the SA node is the pacemaker of the heart, and it generates regular electrical complexes that travel to the AV node and down the bundle branches and into the Purkinje fibers. What happens in atrial fibrillation is that small segments of depolarization occur all over the atria. So in other words, you have depolarization occurring irregularly in hundreds and hundreds of places throughout both the right and left atria. Some of those depolarizations will reach the AV node and generate a QRS complex. Others of those depolarizations will reach the AV node when it is refractory, and they will not generate a QRS complex. The result is that these random depolarizations occurring throughout both atria will lead to a random irregular pattern of QRS complexes, and that generates the irregularly irregular rhythm. There is some terminology we use to describe atrial fibrillation that you should be familiar with. Paroxysmal atrial fibrillation is atrial fibrillation that comes and goes, usually over hours or days, usually with spontaneous conversion to sinus rhythm. Persistent atrial fibrillation is atrial fibrillation that lasts longer, usually days or weeks, and it often requires a procedure called a cardioversion to restore sinus rhythm. We'll talk more about a cardioversion later in this video. And then finally, permanent AFib, as the name implies, is atrial fibrillation that is permanent and does not revert to sinus rhythm. There is a wide spectrum of symptoms seen among patients who have atrial fibrillation. Many patients are asymptomatic and have a heart rate under 100 beats per minute. In these cases, the atrial fibrillation is detected on a routine EKG or sometimes when someone takes the pulse and notices that it is irregular. On the other end of the spectrum, there are patients who have palpitations and dyspnea and fatigue, often with a very fast heart rate over 100 beats per minute. These patients obviously come to medical attention because of the symptoms. Atrial fibrillation can lead to a cardiomyopathy. This is caused by untreated rapid atrial fibrillation, and I've bolded the word rapid because the heart rate has to be rapid to cause this cardiomyopathy. In fact, it's called a tachycardia-induced cardiomyopathy. If patients have untreated rapid AFib for a period of several weeks or longer, their ejection fraction will decline and they'll develop systolic heart failure. And as I told you on the last slide, some patients with atrial fibrillation are asymptomatic, so sometimes the first point where they realize they have AFib is when they develop heart failure and present for medical attention. Let's talk about some of the physiology of atrial fibrillation, and I'll begin with the heart rate. So I told you that some patients who have AFib have a normal heart rate less than 100 beats per minute. Other patients with atrial fibrillation are tachycardic. They can have heart rates as high as 150 or 180 beats per minute. What determines the heart rate in AFib is the AV node refractory period. As I told you before, there are those hundreds and hundreds of spontaneous depolarizations occurring in the atria. They will be sent to the AV node, and if the AV node is refractory, they will not be conducted to the ventricle. However, if the AV node is capable of quickly recovering and conducting another impulse, then many more of those depolarizations will generate a QRS complex. This often has to do with the patient's age at the time they develop atrial fibrillation. So young, healthy patients tend to have very healthy AV nodes, and therefore when they develop atrial fibrillation, they often have a very rapid heart rate. Older patients tend to have an AV node that is not capable of very fast conduction, so therefore they often have a slower heart rate. Just to put this into perspective, the atrial rate in atrial fibrillation is generally around 300 to 500 beats per minute. This is how quickly all those depolarizations are occurring in the atria, but the ventricular rate is usually around 70 to 180. And the reason it's slower is because all of these depolarizations cannot be conducted to the ventricle, and the reason for that is because the AV node has a refractory period, and you can't conduct faster than that refractory period. The preload on the left ventricle is affected by atrial fibrillation. Atrial fibrillation eliminates ventricular prefilling. When the atria are fibrillating, they are unable to contract normally and fill the left ventricle. This is described as a loss of the atrial kick, and this will decrease the preload. This can, in some cases, lead to a low cardiac output and hypotension, especially in patients that are what's known as preload dependent. So, for example, patients who have aortic stenosis need their preload in order to generate enough output to get past the stenotic aortic valve. Patients who have left ventricular hypertrophy or diastolic heart failure have stiff ventricles. They need the atrial kick in order to fill that stiff ventricle. So in these types of patients, you can sometimes see symptoms of cardiogenic shock when patients go into atrial fibrillation with a very rapid heart rate. Atrial fibrillation can cause a lot of symptoms, but in general, the arrhythmia itself is usually not life-threatening. What can be a life-threatening complication of atrial fibrillation is the fact that thrombus can form in the left atrial appendage, and this can break off and cause a stroke. So stroke is a major problem for patients who have AFib. Shown on the screen is a transesophageal image of the left atrial appendage. It is a small outpouching of the left atrium, and it tends to have very slow blood flow, and that blood flow gets even slower in the setting of atrial fibrillation. When this happens, it can form a thrombus, and what you're seeing on the screen is a thrombus filling up the left atrial appendage. If a piece of this thrombus breaks off, this patient will have a stroke. So atrial fibrillation is a common cause of thrombus forming in the heart and causing a cardiac embolism. If a piece of the thrombus travels to the brain, it will cause a stroke. If a piece of the embolus travels to the gut, it can cause mesenteric ischemia. And thrombus from atrial fibrillation also sometimes travels to the spleen and causes splenic infarcts. You will sometimes hear people refer to valvular AFib. So what does this mean? Valvular atrial fibrillation is atrial fibrillation associated with rheumatic heart disease, usually mitral stenosis. Mitral stenosis is uncommon, but when it does occur in association with AFib, that atrial fibrillation is often refractory to treatment, and in addition, it carries a very high risk of thrombus, some of the highest risk of all patients with atrial fibrillation. This is especially important in clinical trials. Many clinical trials of atrial fibrillation therapy exclude valvular atrial fibrillation patients because they are so difficult to treat. So you may hear that a certain drug for atrial fibrillation is approved for non-valvular AFib, and this means that it has only been tested in patients who have atrial fibrillation not associated with rheumatic heart disease. Let's talk about some of the risk factors for atrial fibrillation. Age is one of the most important risk factors. AFib occurs in about 10% of patients over the age of 80 and less than 1% of patients under 55. It's more common among women than in men, and among the associated disorders, the most common associated conditions with AFib are hypertension and coronary disease. AFib often occurs in association with other disorders of the heart that dilate the atria. Anytime the atria become enlarged, this can lead to atrial fibrillation. So for example, patients with heart failure have high pressures in their right and left atria. This often stretches the atrial fibers, and that can lead to atrial fibrillation. Patients who have valvular heart disease often have high pressures in their right and left atria. This can enlarge the atrial chambers, and that can lead to AFib. So if you understand this, then you should understand why a key diagnostic test among patients with new atrial fibrillation is an echocardiogram. We often do this when patients have new AFib to determine if there is something going on with the heart that may have contributed to the atrial fibrillation. Hyperthyroidism is another condition that commonly leads to atrial fibrillation, and in fact the arrhythmia is usually reversible if you treat the thyroid problem. In addition, atrial fibrillation treatments are less effective when patients have untreated thyroid disease. For this reason, another key test when patients have new onset atrial fibrillation is to check the TSH and exclude that they have hyperthyroidism. Let's talk about the triggers that cause patients to go into atrial fibrillation. Often there is no trigger identified, but for some patients, binge drinking can lead to atrial fibrillation. This is called the holiday heart, and I have a small number of my patients who I have to instruct to not drink because every time they drink, they develop atrial fibrillation. Another classic trigger is increased catecholamines for any reason. So for example, elderly patients who develop an infection like pneumonia often develop atrial fibrillation in the hospital. The same thing can happen after surgery. The same thing can happen when patients are in significant pain from a trauma. Now let's talk about the treatment for atrial fibrillation, and there are three arms of treating atrial fibrillation that I encourage you to think about separately. When we treat a patient with atrial fibrillation, we first treat the heart rate. This is called rate control, and ideally we want the heart rate in atrial fibrillation to be less than 110 beats per minute. The second thing we treat is the heart rhythm. This is called rhythm control, and this involves restoration of sinus rhythm. And then the final arm of treatment is anticoagulation to prevent the development of thrombus and stroke. When a patient presents with new onset atrial fibrillation at a fast heart rate like this tracing on the left side of the screen, the first thing we do is administer drugs to slow the heart rate. The atrial fibrillation will persist. These drugs will not eliminate the arrhythmia, but they will slow the heart rate down to a more normal range like this rhythm on the right side of the screen. When you do this, this often makes patients feel much better. What makes patients feel sick and have palpitations and dyspnea and shortness of breath is often the tachycardic heart rate. If you simply slow the heart rate down but let the patient remain in atrial fibrillation, they often feel much, much better. And in fact, for a number of patients, particularly elderly patients, this is all we do. We slow the heart rate down, but we allow them to remain in chronic atrial fibrillation. They will be symptom-free and they don't need any therapies to restore sinus rhythm. The drugs that are used for rate control are beta blockers, calcium channel blockers, and digoxin. So the reason we use these three classes of drugs is because all of them can slow AV node conduction and reduce the heart rate. Beta blockers that are used are usually beta-1 selective agents like metoprolol and atenolol. The calcium channel blockers that are used are those that affect the AV node conduction like verapamil and diltiazem. And then finally, digoxin is used in some cases. It increases parasympathetic tone to the heart and thus slows conduction through the AV node. Now, as I told you before, in some cases, rate control is all that's required. Some patients remain in atrial fibrillation and are free of symptoms. However, for other patients, they are still symptomatic even when the heart rate is slowed down. And in these cases, we need to do what's known as rhythm control. And the goal of rhythm control is to restore sinus rhythm. And this involves doing a procedure called a cardioversion, which will convert the atrial fibrillation shown on the left side of the screen to a normal sinus rhythm shown on the right side of the screen. The way cardioversion is often performed is via a procedure called an electrical cardioversion. This procedure involves use of a machine called a defibrillator. There's an example of one shown on the screen here. And we use the defibrillator to deliver a synchronized shock at the time of one of the QRS complexes. The shock needs to be synchronized because if it is not synchronized, it can potentially occur on a T wave, and this can lead to ventricular fibrillation. To do this, you administer anesthesia to the patient. It's done in a controlled setting. You then deliver an electrical shock to the chest. When this is done, all of the myocytes in the heart depolarize, and usually the sinus node is the first to begin repolarizing and depolarizing again, and thus sinus rhythm is restored. It's not 100% effective, but it usually works in about 80% of patients. There is an alternative to the electrical cardioversion called a chemical cardioversion. This does not require anesthesia. It involves the administration of an antiarrhythmic medication. Usually it's ibutylide, which is a class 3 antiarrhythmic drug. This is done much less commonly than electrical cardioversion, and the reason is because there is drug toxicity associated with using ibutylide. And then finally, I should mention that many patients spontaneously convert back to sinus rhythm. This often occurs after a few hours or days. So when I meet a patient with new onset atrial fibrillation, if they are not feeling too uncomfortable, I often encourage them to give it a little bit of time. After a few days, many of them will spontaneously convert to sinus rhythm, and this spares them the need for an electrical cardioversion. If a patient with atrial fibrillation has a thrombus in their heart and you perform a chemical or electrical cardioversion, you can potentially dislodge part of that thrombus and cause a stroke. Now, studies have been clear that it takes about 48 hours for a thrombus to form. What this means is that if a patient presents with atrial fibrillation and you want to perform a chemical or electrical cardioversion, if the duration of symptoms has been less than 48 hours, then cardioversion is safe. On the other hand, if symptoms have been present for more than 48 hours, or if you're unsure of the duration of symptoms, then you need to consider that a thrombus may be present. You can do one of two things in this situation. You can anticoagulate the patient for 3 weeks and then perform a cardioversion. You also can perform a transesophageal echocardiogram. This is a study that allows imaging of the left atrial appendage, and if there is no thrombus present, then you can perform the cardioversion. The one exception to this is if a patient has hypotension or shock in the setting of rapid atrial fibrillation. In this situation, emergent cardioversion is performed without worrying about whether or not there may be a thrombus. In addition to cardioversion, when we adopt a rhythm control strategy for atrial fibrillation, we often administer antiarrhythmic medications. These are often given before and after cardioversion. For example, the class 1 drugs, flecainide and propafenone, are sometimes used. So are the class 3 antiarrhythmics, amiodarone, sotalol, and dofetilide. I talk about the mechanism of action of these drugs in the antiarrhythmic module, but for our purposes here, you should just be aware that these are often administered before and after cardioversion because they reduce the risk that the patient will convert back into atrial fibrillation after we restore sinus rhythm. The third arm of treatment for patients with atrial fibrillation is anticoagulation. These drugs are administered in order to reduce the risk of thrombus formation and stroke. There are 4 groups of drugs that are used in atrial fibrillation. The first one is warfarin. The downside to warfarin is that it requires regular blood testing to monitor the INR level. The goal INR for a patient with atrial fibrillation is usually 2 to 3, and the INR level needs to be regularly checked to make sure it's within this range. There are several newer anticoagulants that are now options to warfarin. First are the factor X inhibitors. These are rivaroxaban and apixaban. There is also a direct thrombin inhibitor, dabigatran, which can be used. And then finally, aspirin can potentially be used in atrial fibrillation to lower the risk of stroke. The problem with aspirin is that it's less effective than the other anticoagulant drugs I've listed on this slide, so it's only used if the risk of stroke is very low. The upside to aspirin is that there is less risk of bleeding compared to these other drugs. And I talk about the mechanism of action of all these drugs in the hematology section. You might think that in patients who convert from atrial fibrillation to sinus rhythm, they would no longer need anticoagulation, but that is not the case. Whether atrial fibrillation persists or sinus rhythm is restored, anticoagulation must be administered. The studies have been clear that there is a similar risk for stroke whether the patient has a rate control or rhythm control strategy. This probably happens because patients with atrial fibrillation, even when they're in sinus rhythm, do not have a completely normal atria and still have some risk of stroke. In addition, many patients who are in sinus rhythm with a history of AFib have short silent episodes of atrial fibrillation, thus they may still be at risk of stroke even though they believe they are in sinus rhythm. There are a couple of methods that are used to estimate the risk of stroke among patients with atrial fibrillation. One of them is called the CHAD score. This is a scoring system that gives patients points based on their age and past medical history. So if they have a history of congestive heart failure, they get a point. A history of hypertension is a point. Age over 75 is a point. Diabetes is 1 point. And a history of stroke is 2 points. And the first letter of all of these risk factors is what gives it the name CHADS. If the score is greater than or equal to 2, then warfarin or some other anticoagulant should be used for anticoagulation. If the score is 0 or 1, then aspirin can be used. The CHAD score was modified several years ago to a newer score called the CHADS-VASC, which is probably what you will most commonly see used on your clinical rotations. This score gives a patient a point for the same things as the CHAD score. However, it also gives 1 point if the patient is female. It gives 1 point for age 65 to 75 and 2 points for age 75 or greater. And finally, it gives 1 point for vascular disease. Once you calculate the score, you then use the same interpretation system. A greater than or equal to 2 score means you should use warfarin or some other anticoagulant. A score of 0 to 1 indicates aspirin is okay. So here's a summary slide showing how I think about atrial fibrillation. If a patient presents with new onset atrial fibrillation, I often order an echocardiogram to exclude structural heart disease. I also often check a TSH to exclude thyroid disease. We then administer rate control with beta blockers, calcium channel blockers, or digoxin, and in many cases this is all we will do because the patient feels better when the heart rate is slower. In some cases we adopt a rhythm control strategy where we perform a cardioversion and sometimes use antiarrhythmic drugs. And then regardless of whether a rate control or rhythm control strategy is used, anticoagulation must be addressed. It can be done with aspirin, warfarin, or other drugs as we just described. There is a surgical procedure that can be performed in cases of symptomatic refractory atrial fibrillation. The procedure is called a pulmonary vein isolation procedure. It's sometimes called an atrial fibrillation ablation. In order to understand this, let me review a little bit of anatomy. If you look at this drawing of the heart, the left atrium is here on the right side of the screen, and there are 4 pulmonary veins which deliver blood from the lungs to the left atrium. I've zoomed in on the left atrium and the pulmonary veins here, so it turns out that in many cases of atrial fibrillation, the arrhythmia is initiated by electrical activity in the pulmonary veins that travels to the left atrium and triggers the arrhythmia. What this means is you can potentially treat the arrhythmia by electrically isolating the pulmonary veins. This is done with special catheters that burn myocytes surrounding the pulmonary veins. This creates a small area of scar in the left atrium that does not conduct electricity. Thus, if one of those impulses begins in the pulmonary veins, it is unable to travel into the left atrium, and therefore the arrhythmia does not occur. I'll finish this module by briefly discussing atrial flutter, which is another cardiac arrhythmia that has many similar symptoms and treatments to atrial fibrillation. The key distinction is in the EKG. This is an EKG of a patient who has atrial flutter. Notice that there is a sawtooth pattern to the waves before the QRS complexes. These are called flutter waves, and you can see them in every lead on this EKG, and that is consistent with atrial flutter. What's happening in the atria in atrial flutter is different from what occurs in atrial fibrillation. I told you before that in atrial fibrillation there are hundreds and hundreds of parts of the atria that are depolarizing spontaneously. In atrial flutter, the aberrant electrical activity is much more organized. There's usually a circuit in the right atrium with electrical activity going around and around the right atrium. Each time it goes around the right atrium, it generates one of those sawtooth flutter waves, and then some of those waves are conducted to the ventricle, and that generates a QRS complex. The symptoms of atrial flutter are generally the same as for atrial fibrillation. Many patients are asymptomatic, just like in AFib, but some patients develop palpitations and dyspnea and fatigue. The treatment is also generally the same as for atrial fibrillation. You can adopt a rate or rhythm control strategy. Rate-slowing drugs can be used, cardioversion is sometimes performed, and anticoagulation is administered based on stroke risk. There is a risk of stroke in atrial flutter, just like there is in atrial fibrillation. There is one treatment, however, that is unique to atrial flutter that is not used in atrial fibrillation, and that is a surgical ablation procedure called an atrial flutter ablation. As I told you before, the arrhythmia in atrial flutter is organized. It's usually a circuit traversing the right atrium. What this means is if you use a special catheter and you burn a line of myocytes in the right atrium, that will disrupt this circuit. In other words, electrical activity will no longer be able to circle around the right atrium because it will encounter this scar tissue that does not conduct electricity. This will eliminate the atrial flutter arrhythmia, and it can potentially be curative. This is a far more straightforward procedure than an atrial fibrillation ablation. Don't confuse the two. An atrial fibrillation ablation involves the pulmonary veins, it's very complex, and it has a limited success rate. An atrial flutter ablation is a much simpler procedure and it has a much higher success rate. In many cases, it eliminates the arrhythmia. And that concludes our module on atrial fibrillation and flutter.